Good afternoon. Today I'll be talking about a case study for invasive ductal carcinoma of the breast with suspected metastasis to the liver. For context, our patient is a 65-year-old female, non-smoker, occasional drinker, and mother of three with no history of familial breast cancer. After review, preliminary diagnosis of invasive ductal carcinoma was made, which represents over 80% of all breast cancer diagnoses and is defined as a malignant tumor formed from glandular tissue lining the epithelium of milk ducts. On this cross-section of normal breast tissue, we can see normal ductal lobular structure with subsegmental ducts, giving rise to several terminal duct lobular units embedded in dense collagenous stroma. Normally, one terminal duct should give rise to an anastomosing collection of smaller ducts referred to as the lobules, separated by stroma into well-defined units known as acini. Acini are usually composed of two layers, one complete outer basal layer of myepithelial cells and an inner luminal layer of cuboidal to columnar epithelial cells, surrounded by basement membrane and surrounding stroma. We can expect to see some normal age-related changes in a post-menopausal woman as listed here. However, because these changes may also precede or be associated with cancer, it is important to follow investigation with histology. Biopsy will allow for the determination of histological molecular cancer subtype, which has an implication on the prognosis and treatment options. Although there is one normal duct present here, as shown by the intact myepithelial and luminal double layer, the tumor is still forming tubular structures, and outside of which we see disturbance to healthy ductal and lobular architecture, with solid masses of neoplastic cells obscuring duct lumens and invasion of tumor islands into adjacent stroma and fat tissue. Invasive ductal carcinomas will form from a ductal carcinoma in situ precursor and are indistinct apart from the epithelial infiltration into stroma. We can notice the extension of epithelial tissue lining ducts beyond basement membrane into duct and causing fibrous response as shown here. This is known as desmoplasia and may be responsible for the palpable mass found upon examination. When the lump is non-mobile, as in this case, it suggests infiltration and metastasis into surrounding tissue and distant organs through lymphatics or blood vessels. The extensive desmoplasia distinguishes invasive ductal carcinoma from other breast cancer subtypes like invasive lobular carcinoma, which will have a minimal fibrous response. On the normal immunohistochemical staining, we see a complete layer of myepithelial cells surrounding the duct. On the patient sample, however, patchy immunoreactivity with keratin 5 antibody demonstrates a mixed cell population, epithelial hyperplasia, and absence of basal cells. Lack of complete membrane staining distinguishes this cancer from ductal carcinoma in situ, in which the duct membrane is intact and epithelial cells are not invading surrounding tissue. Loss of circumscribed myepithelial cell layer with smooth muscle myosin staining is also a useful diagnostic tool in recognition of invasive carcinoma. Only myofibroblasts within blood vessels will stain. We can see the same pathology in liver as in the breast, including single files of tumor cells running through stromal tissue, invasive tumor nests, and total loss of hepatic parenchyma, as demonstrated here in the normal liver sample. An increase in presence of spindle-shaped cells within the fibrous stroma is indicative of desmoplasmic reaction against invasive tumor. Presence of tumor vasculature will denote the tumor angiogenesis. Immunohistochemical staining with antibodies for estrogen receptor protein has stained units proliferating from inner epithelial cells, demonstrating presence of estrogen-positive malignancies outside of ducts in breast stroma. Similarly, HER2 stained positively, highlighting total membrane staining amongst infiltrative tumor nests. Similar patterns for staining for breast cancer proteins are seen in the liver, including estrogen receptors contained within neoplastic basal and myepithelial cells, and HER2 membrane staining of the breast tissue. In conjunction with routine staining, we conclude metastasis of breast malignancy into liver. Staging is based on TMN system, giving further information on prognosis, best treatment, and suitability for clinical trial. Results from histopathology, together with discovery of 3 cm mass, distal organ metastasis, and need for radical mastectomy and the removal of lymph node axilla, together suggest stage 4 or advanced classification. Staging and results qualify patient for systemic therapy following surgery, including chemo, radio, and adjuvant hormone therapy. Thank you for listening.